Good morning, everybody. Welcome to WFLHCA, West Florida HCA. This is Beaumont Smart Dog Productions. Today we're going to talk about co-triaging in the emergency room with advanced cardiac imaging with an ARNP and an imaging cardiologist. So that's our topic today, how to evaluate chest pain with advanced cardiac imaging. At our disposal are cardiac CT, cardiac MRI, echo with strain in 3D. So this is Memorial Hospital where we're going to start this pilot project with the emergency physicians, and we're launching it very soon. Right now we're telling people about it, and so this is part of our learning curve in involving this in the emergency room. We don't want anybody to be surprised. They want to have their expectations and to understand what we're doing. So we're glad you're here and we can tell you about this. So we're going to start with a case, as we do everything, because it's always about patients and patient-centric care. So we have a patient that is a 42-year-old African-American male who comes from the base. We're very active with MacDill Air Force Base, especially the SOCOM and CENTCOM. And this gentleman came to our clinic early in August with palpitations and some shortness of breath. And he was going to have surgery of his foot. And but his symptoms were more frequent and more severe after he had the surgery. And he'd been prescribed some anxiety medication. States it didn't help with his palpitations and with his symptoms. He denied the use of caffeine or dehydration. He didn't have much in the way of chest discomfort. It was more epigastric. There was some lightheadedness, dizziness, orthopnea. He didn't have no peripheral edema. And so he had an interesting EKG, and for that reason he was referred, and because of his symptoms. His right foot was operated in May, right ankle foot fusion with multiple screws. So when you see that and you see his foot, you think of immobilization, and of course pulmonary emboli is going up your list. He is on Percocet 325/5, and he has been a smoker in the past but quit after his surgery. And his father had some bypass surgery at 64. So there's a family history of that, no family history of hypertension. There was nothing impressive about his lab except triglycerides were 254, HDL was very low, LDL 148, total cholesterol 209. And then he had a pre-op EKG, which was abnormal, and this keeps coming up, his EKG being abnormal with ST and T wave changes. And I think the EKG is what prompted him having, before surgery, a dobutamine stress echo at Tampa General Hospital. And the question is, was this a good choice? And as you know, the gold standard, because of FAME-1 and FAME-2 research studies, if FFR, fractional flow reserve, which is basically done by doing a cardiac catheterization, putting a wire across a lesion that's identified, that is identified as a possible culprit, and then injecting adenosine, and then pulling the wire back from distal to the plaque to proximal to aorta. And that pullback becomes the standard of care for our stenting or bypass surgery if the FFR is less than 0.80. And so that is our standard today. And so we used to basically say you had coronary disease and you had a lesion that's 70% or greater, and correlated that with our stress test. That's not good enough now, so it has to be correlated with FFR. And so as you see, the sensitivity is extremely low and the specificity is not very high either. So stress echo with dobutamine, he couldn't exercise because of his foot. He's going to have foot surgery, was not a good choice because it doesn't get you a bottom line answer of does he have conceivably a lesion that's severely stenotic that would give a positive FFR. So what was the standard not too long ago has now migrated to be under the standard of care, and with FFR being the new gold standard, has to basically correlate with FFR. So although normal baseline echo, normal heart rate, blood pressure, normal ejection fraction during rest and stress, there is no conclusion. Patient did go on and have surgery. This is our seeing the patient after that, referred to us in this clinic, and you can see that the dobutamine stress echo was not impressed, did not impress anybody. Patient is being referred out for cardiac evaluation, even though he's already had a so-called cardiac evaluation. And so the SPARC study, SPARC, actually showed that many non-invasive tests are ignored today. Patients go on to cath. The reason why the results are ignored is the results don't correlate with FFR. Yet we're still in the same pattern of doing tests that don't correlate with FFR because we believe that's standard of care and we don't think we have anything better or any alternatives. So he did have some impaired mobility, had pulses. I couldn't tell about the foot as far as edema. Took his little boot thing off, but it looked like there was some edema there. And so what do we do next? And this is the question we always ask. And so in terms of what to do next, well, how about an EKG? So let's go look at this EKG on this patient that seems to get everyone disturbed. So yeah, here's his EKG, and well, it's almost like he has a short QT, because all of a sudden at the sort of J point, there's a takeoff of an upward coved ST segment, giving this ST segment elevation. Well, if someone came in the emergency room with chest pain, that would be impressive to you, because it's not the usual early repolarization that we see in young males. And so this is kind of suspicious. It would also be suspicious of hypocalcemia because of the short QT. So it's an interesting, or maybe electrolyte imbalance of some sort, but it's an interesting EKG. But if you go back over this patient's chart, you'll find that this is always his EKG, and so it never changes. So it's not an acute pattern for this gentleman. So the fact that it's not associated with immediate chest pain and not an acute pattern makes it of less importance, but it's still important because he was pre-op recently, and because of this got a dobutamine stress echo. Still didn't solve the problem of what's wrong with him and what's wrong with his EKG. So let's see what we did after this. And so these are the choices. Well, he's had a stress echo. He's had a stress test. These are other choices. He does have palpitations. Holter monitor might be a good choice. Cardiac cath is something that carries with it considerable complications because it's an invasive test. Patients don't like it. There's not a lot of satisfaction with, I went to the hospital and had a cardiac cath, it was normal. And so let's look at some of our other choices. And so since I saw him in consultation, I was interested in what his TSH was. I also was interested in his arrhythmias, and we have something called a Zio that you can actually wear for 2 weeks. And unfortunately, you don't get the arrhythmias immediately. It's analyzed, and you get the information afterwards. So that's unfortunate, but it's like about the size of a Band-Aid. It just fits on your chest. You can take a shower with it, and so it's so mobile and so unrecognizable as being something on a patient, as opposed to Holter monitors where you got this big box you're carrying around with wires. And so it makes a lot of sense. And so we frequently use that on people who have palpitations who don't have them very frequently, and we need a long-term analysis. Cardiac CT, as you know, we're strongly committed to cardiac CT because when you look and see, you can see if there's any coronary lesions immediately. A negative test is 99.9% sure, and so it's just good to get a good value test. And so this is actually, in many times, superior to, if not equal to, cardiac cath. Superior to in that we get wall analysis, equal to in that we're looking for intraluminal abnormalities. So unfortunately, the test isn't readily available, not because of equipment, but because of insurance company denial. And so the insurance companies are practicing with the old pattern as if FFR never came into being. And so the FAME 1, FAME 2 studies are completely ignored by the insurance companies, and basically I don't know how they work, but I do know that the denial is handled by radiology benefit managers who basically are paid to deny CT, MRI, and PET, which they are considered expensive tests. They've been paid for the last 10 years to deny those. If they deny 15% of those, they will save $3 per member per unit of time, and they'll be paid 25 cents per member per unit. Excuse me, they'll be paid 25 cents per member per unit of time, and then that'll multiply out to be $250 million a year if you have enough patients involved in this system. And so at one point I had some meetings of radiology benefits managers representing several companies, and we had at the table representatives of 40 million people. And so it's pretty amazing. And so they control the industry, and they actually control the standard of care, and basically in some ways incorporate guidelines as self-serving dictums to use to deny certain tests. So what to do next? And now he's in the ER, and let's go see what happens in the ER in somebody like this. And so of course there's going to be immediate acquisition of an EKG. And so here's our EKG. Now this EKG is much more impressive. Somebody who shows up in the ER with chest, abdominal, epigastric pain and is 7 out of 10, and then has this EKG, and the physician is naive to any other EKGs this patient's had, and we got, well, it's kind of diffuse ST segment elevation. Certainly looks like the early repo pattern in some ways. Other ways looks like acute pericarditis, ST segment elevation in several lead systems. Here we go, V6, V5, V4, V3, V2, and then we got lead 1, lead L, we got depression and AVR. We've got lead 3 with flip T waves, which is very common. We got lead 2. And so it's a very impressive, looks like the short QT interval as before, maybe a U wave beyond here. And so very interesting EKG. The PR, well, the PR could be PR depression, or it could be ST elevation. Well, the baseline's here, so it's ST elevation and not PR depression, but based off the baseline. So this is the EKG, and so any self-respecting emergency room doctor would immediately be treating this patient as an acute cardiac event. But luckily we got old EKGs on his chart. Luckily we saw him a week before and got EKGs, and his symptom has some atypical features. So at 10:29 is when he showed up in the emergency room, and he obtained his EKG almost immediately. He got a chest x-ray of 10:40, and by this time we had EKG, ST changes like before, so that made it easier for us. D-dimer is negative, even though it's got a boot on and he's immobilized because of surgery in his leg. His D-dimer is negative. Troponin negative, number 1, point of care. TSH, well, I got my TSH and it was okay. Remaining labs are normal. Chest x-ray is normal. So now we got to the point of, what are we going to do about this gentleman? And of course the ER is very antsy about getting people out of the ER because you've got to be ready for the next one to come in. So get out of my emergency room. It's called Gomer, by a very famous book that we read as interns and residents. And so it's time to get out of my emergency room, free up the bed, and so that means you go to observation. So how are we going to take care of this patient? How are we going to rule this patient out? Well, I think we're going to stick with our previous course, which basically we're going to be gunning for a CT on this gentleman because that gets us right to the bottom line. And we don't think he's an acute cardiac problem. We don't think he has acute coronary insufficiency. So let's go to our new Memorial Hospital risk score, and it's called the 0 score. Well, let's see. 80% of chest pain patients don't have acute coronary insufficiency, pericarditis, dissecting aortic aneurysm, or pulmonary emboli. And so given that, let's look through what we think is helpful to separate out the low-risk patients. Well, what are the options for evaluation? And the options for evaluation are there's a GRACE score, there's a Duke score for chest pain, there's a TIMI score, there's a heart score. There are many score systems that have been evaluated, but I've been doing this for a long time with running chest pain centers, and so I came up with my own score, which we're going to call the Memorial score, or the 0 score. And so basically prior cardiac history negative. Well, that's a big one. You know, if we can rule out he's never had a heart attack, stents, or bypass surgery, we're moving on pretty good. So we got to check that for sure, because anybody who has previous coronary artery disease is at high risk, and we don't care what's wrong with him. We got to review that and rule that out. Does not have classic angina. Well, for males, that's pretty valuable. It's also valuable for females. And so if he doesn't have classic angina, then we're moving along pretty good, because we can usually recognize exercise-induced chest pain relieved by rest, lasting 10 or 15 minutes, relieved by nitroglycerin, brought on by exertion, and so forth, accompanied by dyspnea and different kind of discomforts in the chest. Normal echocardiogram, well, we've already had that. Not only do we have a normal echocardiogram, we have a normal dobutamine echocardiogram. And so we're happy with that. Normal and non-specific EKG, well, we have past EKGs, so the EKG can quickly be nullified because they're all the same. Immediate family history, well, he does have family history, but his father's older, and so when he had bypass surgery. So it's not a younger parent or a sibling. It's not the same thing as the early onset at a young age. And so first troponin negative, yep, we got a first troponin negative, point of care, takes about 10 minutes right by the bedside. So it looks like we're set already to put him in this 80% classification of chest pain. And in this 80% classification, we're only wrong 1 out of 100. So, and not really wrong, we're looking for the needle in the haystack. In this 80%, there's only one person that may have gotten through this sieve that could have coronary artery disease, maybe unrelated to his current symptoms, but could have coronary artery disease. So we're looking for the needle in the haystack now. So what to do next? Well, we can do an echo. What about pulmonary emboli? Well, the D-dimer is negative. We're not going to really focus on that. That's usually a pretty good rule out. He has been immobilized. He does have something on his foot from his surgery. A stress test, SPECT scan tomorrow, and that's always the option in every hospital, and that's an option that we don't elect. Cardiac CT, how about a triple rule-out CT, not just a cardiac or a coronary CT? How about we rule out pulmonary emboli at the same time they will rule out dissecting aortic aneurysm, even though we just don't really suspect that, because you usually have hypertension with that, and a history of hypertension at least. And we rule out coronary artery disease. Well, we can do a Lexa scan and CMR. Obviously, if we can't get his heart rate down, and then we got to do something else, and Lexa scan would be a choice. But if he's had caffeine, Lexa scan's out of the question, and we have to wait 24 hours to get the caffeine out of his system, or at least 12 hours. Well, let's see. We've got dobutamine. He's had dobutamine before and tolerated it well, and so that would be another choice if we can't get his heart rate down and if he's already had caffeine. So we've got choices. Telemetry, you know, he's going to be on telemetry for a little while, not long. Cardiac, I'd rather have the Zio over a period of 2 weeks and record his heartbeats. Cardiac cath tomorrow, that seems to be a very, very frequent option. And I saw a gentleman yesterday who had a left bundle branch block and who was an outpatient evaluation for some palpitations nothing else, maybe a little dyspnea on exertion, who had a SPECT scan that was normal, but he had some transient dilatation of the heart during the SPECT scan, which is not uncommon and nonspecific. So he went to a cardiac cath, so-called tomorrow, and had a TIA during the cath. It's pretty scary, some of the things that can happen during the cath. He said he heard the doctor say to the tech, "Oh no, you didn't do that." And so we think he may have been some injection of some air in the system. And so he had a little TIA, recovered very rapidly, but there are certainly hazards with cardiac cath, and I'm never going to minimize those. So CTA today was our choice for a triple rule out. Well, let's see, we've got a heart rate of 78. Whoops. Well, we've got a problem because we got to get the heart rate down, but we're not worried about the ER bed anymore because he's being sent to observation. So with that in mind, we want to do the lowest radiation procedure we can do, which is coronary CTA, step and shoot and iDose, which gets the radiation in the 3 millisievert range, somewhere between 2 and 5, depending upon the body size. And so we've got to get the heart rate down. So the ER is our site on the way to OBS, and so we just order to the CT nurse to give ivabradine 15 milligrams, which is a funny channel blocker and blocks only the SA node and slows down the heart rate. Ivabradine is used in patients with congestive heart failure who don't slow down their heart rate with beta blockade. Ivabradine is frequently used now with inappropriate sinus tachycardia, and now we have another opportunity to use it for slowing down the heart rate to do a coronary CT without worrying about the blood pressure that comes from beta blockade. So, but we got to wait for 2 hours, but that's okay. We've still got stuff to do. He's going to observation. We can get our second troponin, and we can be doing other things while we're waiting for this. So at 227, that's not bad. 1152 ivabradine. And now we're 227, we're over the CT scan, and look, 3 o'clock already, and we've got normal coronaries, no evidence of aortic dissection, no evidence of pulmonary emboli. So we had an arrival time of about 10, and 10:29 was the arrival time of the doctor with the patient in the emergency room. And so now at 3 o'clock, I'm delivering a normal coronaries, no evidence of aortic dissection, no evidence of pulmonary emboli to the emergency room doctor, printed as a preliminary report. So not bad. Now we can start talking about what else are we going to do with this patient. Well, we could discharge the patient, but unfortunately his pain is 7 out of 10. And so he's needing little doses of medication to keep his pain under control. And so that's a good reason for continued observation. Well, we can continue his workup. He hasn't had anything to eat or drink yet. And so, hey, why don't we rule out gallbladder and gallstones? So it's easy to say, okay, don't have anything to eat or drink. We're going to take you down to X-ray, and we're going to do an ultrasound of the abdomen and look at your gallbladder. So that's quick, and we did that, and it was normal. And then somebody comes along and says, how about a CT of the abdomen? And so that's being done. And we think about, well, I think about, how about an EGD in the morning? So let's put in a GI consult, and let's start thinking about gastritis now, esophagitis, duodenitis, junitis, esophageal erosion, hiatal hernia, gastric polyps, and all the other stuff that can give you abdominal discomfort other than gallstones and gallbladder. So that's the plan at this time. And of course, we've done the research in the past where we had a group of patients that we admitted, did stress echoes on. If they were negative, then we did EGDs. And we most frequently found gastritis, esophagitis, gastric ulcers, esophageal ulcers, erosion, all the different findings that we find in the GI tract with people who are having an acute GI discomfort. So going through all this, he did get the EGD. There was some lag time, there was some wasted time, there was some lost time, but here we are at 5:30, and he's discharged from the hospital finally. He would have been discharged, obviously, the day before. We could have discharged him in 227 if he didn't have all the discomfort. So out of patient compassion, we still had a problem. We've done the rule out, but we haven't done the rule in. And so 50% of people who go home from the emergency room have the rule out, but not the rule in. So they don't know why they went there in the first place and what was wrong with them. They don't have a diagnosis. And so we got a diagnosis, and we got him under treatment. He's taking protonics, and now he's on his way home. So this is new cardiology, and this is the ability to rule out severe cardiovascular disease in a rapid fashion, quality equal to that of cardiac cath, if not greater, in terms of being able to get information about pulmonary emboli. That would have been a lot of dye injection. Aortic dissection, that would be a root injection in terms of cardiac cath. And so we got the information very fast, and we did better than just doing a CT scan that's not gated and looking for a pulmonary emboli. We got the whole ball of wax. So what is the value of this? What is the value of this to the hospital? What is the value of this to the insurer? What is the value of this to the radiology benefit manager? Obviously, it's cost them a lot of money to not affirm or confirm the CT scan in a speedy manner. So by delaying confirmation of the CT scan as an outpatient, we got a hospital admission. Well, it's an observation admission, but it costs money to deny stuff or to evaluate it for approval. And so that was a cost. There was less time in the hospital with CT, obviously. There was length of stay was 1 day, a little bit over 1 day. Could have been less than 1 day if we didn't have further things to rule in. Patient satisfaction. The patient doesn't have to wait for a stress test the next day. The patient doesn't have to get an isotope, doesn't have to get high radiation exposure, avoids unnecessary cardiac caths, allows rule outs so as to move on. So we got enough time left over that after we did the rule out that we can go ahead and do our rule in. And so, and still get away with a much less length of stay. So let's look at that a little bit and talk about co-triaging ER. And so we always kick off with a patient because it's patient-centric. It's always about patient care. So you've had your patient now. You can see how that really worked in reality and the times that were involved. So this is a picture of what we do. Well, it looks very complicated, but it's actually pretty simple. The thing that makes this complicated is that females present with many different symptoms when they're having an acute MI. Our job is to look for acute coronary insufficiency. Well, there's going to be some STEMIs, maybe less than 5%. There's going to be some non-STEMIs, that'll be another 3% or so. We're going to have some acute coronary insufficiencies, which is going to be another couple percent. And then there's some pulmonary emboli and pericarditis and the rare aortic regurgitation. And so, so we got to be inclusive, and we got to throw the net, cast the net wide to get females because of the diversity of presentation. So, but the males, we've still got our classical angina, except it might be on the right side rather than the left side. It's substernal discomfort. We don't say chest pain. And so we said chest pain up here, but it's more better focused if you say discomfort. People are going to respond more positively. Some people vehemently deny chest pain, but they've got chest discomfort. So it's all a matter of semantics. And so the triage nurse, the ER doctors are focused on these people. They're looking at them coming in. They're trying to decide what are we going to do with them. And if we had this kind of profile, then the nurse who's doing the triage can recognize this profile, the so-called cardiac profile, and institute a cardiac selection system that gives us an opportunity to rule out acute coronary insufficiency. And so we got the troponin stat, again, 90 minutes, and then again in 12 hours if the patient is in obs or admitted. We got the EKG stat, again in 90 minutes, again in 12 hours the patient's admitted. But the EKG stat doesn't mean much if it's just read by a computer. ER docs are not highly skilled in reading those. And so how are we going to get information? Well, it's in the Muse. And so I can access the Muse, and I can access the Muse system where I can, before it gets into the panel or before it gets into a doctor's bucket, I can take a look at it when it's just in the Muse and hasn't been differentiated and paired with orders. So I can easily look at that and have access to that without it being faxed to me. So access to Muse and access to Muse Review prior to it getting into my basket or the panel basket. The BNP stat is very important. The WISE study, which is women's initiative, basically looking for symptoms of heart disease, showed that many women with acute coronary insufficiency come in with a positive BNP, negative troponin. So we've learned in our ER that that's extremely important. We were the first user of BNP in this part of the United States, and so we had a lot of data that we accumulated on BNP early on. Urine drug screen, well, that's pretty important. We've seen not only people who are young people, middle-aged people using cocaine and other drugs that cause chest pain, but we've also seen it in older people that have become coke users. And so this is a quick rule out for us. And then the echocardiogram is extremely important, that we look and see about wall motion and get that study in centricity so it can be accessed by the cardiologist remotely. And so that's easy to do also in terms of getting a stat EKG and entering it into centricity. And why do we want to do the, stat echo? Why do we want to do the echo? We want to do the echo because less than 1% of people with acute coronary insufficiency have a normal echo. And so normal echo is so unheard of in acute coronary insufficiency that I've saved the two that I've seen in the last 20 years of my career that have been positive with acute coronary insufficiency. Sure, you can get it with angina. You can get a normal EKG. Sure, you can even get it with progressive angina, but not with acute coronary insufficiency, not with a troponin-positive cardiac event. And so that's a helpful discriminator because I've already gone into the less than 1% range when I have this echo. So once we get the one troponin and once we get these things underway, we can move over here because this is my bypass track for low-risk patients where we can immediately look to see if they have a 0 score, and if they have a 0 score, then we can jump right over here to cardiac CT, dobutamine or Lexiscan MRI, depending upon whether they're claustrophobic or whether they have caffeine or haven't had caffeine, or whether we can get their heart rate down. So we can move right over there. Now we got these patients that don't quite sort out, and so they're going to get the second troponin, the second EKG, and then we're going to review in the Muse the EKGs, make some decision. And so we've got early cardiology involvement with Co-Triage, either with my ARNP, who will be very much available in the emergency room to see patients being triaged and Co-Triage, and basically myself backing them up. And then we have telecardiology with the robot, where we can use the robot used for neurology and access information in the ER and actually talk to a patient at 2 o'clock in the morning or whatever, and practice that, because eventually you'll be using that in rural communities, rural HCA hospitals, where you don't have a cardiologist that's readily available. They sometimes in rural clinics, cardiologists come in once a week and see patients. Sometimes they come in for a day, do an overnight, see patients, and then leave the next day. And so there's lots of rural type systems that don't have access to cardiology and don't have access to neurology either. So they go out and buy a teleneurology robot unit, and we can easily hook up the stethoscope and segue that into cardiology as well. Or you can use a phone, and there's several phone systems that you can buy into that facilitate HIPAA-compliant data that can't be intercepted, that don't have access to information going to the wrong place. And so we can get that just as well. So let's go on. Here's our low-risk memorial score that has been true and tried with me, that I've been using for at least 15 or 20 years now, and have kept evaluating and evaluating until we got exactly where we need. And here's a triage chest pain encounter note that my ARNP or my PA or myself or all three of us or two of us would be basically evaluating the patient and putting the demographics down, looking at the chief's complaint, looking for a history of coronary artery disease, looking for anginal equivalent, doing our score, checking the heart rate, iodine allergy, claustrophobia, no MRI, iodine allergy, got to pre-medicate, caffeine, decaf, no Lexiscan, diabetes is important to know about, hypertension, high cholesterol, cigarette smoking, and family history of coronary artery disease using our risk score. Stat EKG, and we get the time. We diagnose if they have a STEMI and they're on their way out of here because we don't have cardiac angioplasty or back up open heart surgery. Stat echo, the time's important. Looking for regional wall motion, you can actually inject some contrast called Definity, and that makes it even more sensitive for regional wall motion abnormalities. Again, less than 1% of acute coronary insufficiency patients will have a normal echocardiogram. And then incidental pertinent echo findings. And then our stat markers at point of care, where we have the Abbott troponin I, which we can measure within 5 or 10 minutes there in the emergency room and get the information, have the results. We also, there's an NT-proBNP stat point of service information that we can obtain. This is better than the BNP because the BNP has a 22-minute half-life. So this will tell us congestive heart failure yesterday as opposed to BNP would miss congestive heart failure 2 hours ago. And then second troponin, if we haven't gone down the fast pathway of the 80%ers who are going to be very low risk, then we can go to second BNP. There's a lab, second troponin, there's a lab troponin you might get as well. The non-STEMIs are really important because there are non-STEMIs that are going to go to the cath lab immediately and within 90 minutes. And those non-STEMIs are the ones that are hemodynamically unstable, who continue to have chest pain unrelieved by medications, and so who have some significant ST changes that are persistent. And so the non-STEMI by European criteria, having those findings would go to the cath lab immediately. And then there's cath lab within 24 hours, and then there's cath lab within 72 hours, depending upon how you break down the non-STEMI. And so then we've got discharge, office follow-up, admission as an inpatient, observation, our continued ER workup in unstable patients, and of course transfer. And so we have the CTA time. We use step and shoot and iDose if the patient isn't too large, and if we think we can get adequate pictures. That's avoiding radiation exposure. And making a very low dose. We can do a helical. We can increase the KV on a big person to 140. We can decide how much contrast to use. We can use 85 cc's. We can use 70 cc's on a skinny person. We can use on a large person 100 cc's. We've got pre-meds with ivabradine. Right now we've got oral. We'd like to have IV ivabradine. We'll probably do a research study for that. We got IV Lopressor, which is one of our choices that we take all the time in the CT lab when the patient's there. And then we basically, it's in progress, it's completed, it's loaded, it's read, it's dictated, and then it's reviewed with the patient. And of course, with our new Vital Images workstation, we can actually get access to it and show it on an iPad to a patient in the emergency room, as well as to the doctor in the emergency room. So that's pretty important. And then we got the results, okay? We got the final time, we've got some normal, focal non-obstructive calcification, vulnerable plaque, chronic total occlusion, somewhere intermediate that we can't make a decision because there's a lot of blooming artifact from calcium, severe obstruction, and vulnerable plaque, which is very interesting to our group in terms of our research. And so then we apply the CT to the patient in terms of perhaps triple rule out, no pulmonary emboli, no dissecting aortic aneurysm, no coronary artery disease. Our focal coronary calcifications, one and done, good prognosis, less than 1% chance of having a cardiac event on follow-up long term. And then, well, if we can't get the heart rate down, then we've got an MRI protocol. We got a fast protocol with a fast track with like a 30-minute test. We can use Lexiscan if there's no caffeine. If there's caffeine, we got a fast protocol for atropine dobutamine, which is so fast that the patient doesn't get the side effects that they get on lingering drips when you're actually going up on the dovitamine protocol slowly, which causes nausea and vomiting, which we don't want in the MRI suite. And so the fast protocol is better. And then we get the final time, final results, normal, abnormal, reversible ischemia, scar, wall motion abnormality, additional pertinent findings, and then applying this to this patient. And then we've got what's happening. We've got discharge, follow-up, date, transfer to another hospital, out the door time, admission to the hospital, OBS, inpatient status, and a final disposition statement signed off by the ARNP, the PA, and cardiac imaging specialist. So that's kind of how we see the system moving through evaluation and early encounter with the patient. So let's talk about legacy cardiology, because it always comes up. You know, can't I just do a spec? And what about we just do a coronary angiogram and, oh, that looks pretty bad. Let's put a stent in there. Or let's put a stent over here. And so, unfortunately, this test does not have the high octane performance that we need in comparing to FFR. So, obsolete. Cardiac cath has a lot of risk. Cardiac cath, if you're just going to look and say that's a bad lesion, you're going to make some bad decisions, because 50% of the stents that you put in won't be needed because the patient won't have a positive FFR. So FFR is the bottom line. And so spec and cath, which actually, that's what I've heard doctors say. I've had a patient in Brandon that I called the physician because it was my patient who was over there, and he said, let's do a spec and cath, you know. So the spec is frequently ignored. It's substituted for current standard of care by the insurance company, and frequently the results are ignored because of 50% false positive, 50% false negative. So here's the cardiology six-pack. You've heard me say this before: history and physical, EKG, echo, spec, and cath. If a patient is touched by a cardiologist, the average cost of the medical system is $7,000. That's because the gatekeeper has a 40 to 88% false positive, 40% false positive in Michigan at 47 hospitals, 88% false positive at Ottawa, 80% false positive at a university I'm not going to mention, 65% false negative at university at actually Michigan, state of Michigan, Blue Cross Blue Shield study. And so, and it leads to downstream test and downstream manipulations of the coronary system that may not be needed. And again, poor correlation with FFR. Well, how long does traditionally evaluating a patient take? Well, this is what we see quite a bit, where patients admitted ER, low or intermediate risk, you know, gets troponin, another troponin, EKG, echo. It all goes to the doctor's box, and then cardiologist, if he's an interventionalist, comes by late that night after finishing rounds on all the interventional patients and finishing the interventional, gets the echo, looks at the EKG, comes up, may have to wake up the patient, you know, 11 o'clock at night, say, okay, we've seen all this stuff, we're going to do a SPECT scan tomorrow. So out of there, into the lab the next day, with angioplasty and peripheral vascular manipulations on different patients. And this patient is scheduled for a SPECT, waits around, somebody show up. Somebody shows up, they try to book them all at one time and do 3 or 4 SPECTs at one time with Lexiscan. And then they all basically go over to get the images, and then 3 hours later they get the rest images. So it takes a long time. And then back again at night, late, after finishing the lab, and review the results and then make a decision. And this hospital would be transferred to Tampa General. So then the patient gets transferred to Tampa General, realizing that there's a 40% false positive, 65% false negative in 47 centers in Michigan, and there's high radiation exposure, at least 12 to 18, maybe 22 millisieverts. The patient gets to the hospital. 60% of patients getting cardiac cath have a negative cardiac cath, 60%, and then they're home. Well, patients are not happy with this. They're not happy with the risk they take. They're not happy with the discomfort. They're not happy waiting around for somebody to do the test. They're not happy being wakened up at 11 o'clock at night. So you're not going to get a good response if this is your protocol. So let's look over here and say, well, we also know that unless you do an FFR, 50% of the stented vessels don't need stents. We've got the diagnostic false positive SPECT scans running 60% negative casts. And we have the negative SPECT scan for the false sense of reassurance because of the 65% false positive rate. So what is FFR? Well, FFR is where we got a catheter in there, we're putting a wire that's a pressure sensor across the coronary artery lesion, and we're measuring the pressure here. We're injecting adenosine, and that's maximal stress, and that dilates this arterial bed distally, and then we measure that pressure, do a pullback, and measure the proximal pressure or the aortic pressure, and then make a ratio, distal pressure over proximal pressure with hyperemia, which means adenosine, and then that gives us this ratio, which is measured here, and this is distal, and this is proximal, and this is the ratio is 0.74 in this particular patient, and 0.80 is normal. And so only 6% of cardiac casts currently in this country are getting this FFR. However, there are some people that are doing FFR at least 80% of the time when they think it's needed. And then there's people who do IVUS because you do the IVUS, they say, I can look at it, I can look and see, and chances are if you do an IVUS, they'll get a stent. Chances are if you do an FFR, they'll get the stent if they need it. So it defines the functional lesions and significance of coronary lesions, and basically this is the gold standard today. And so any tests have to be correlated with FFR, and you can see SPECT scan sensitivity, FFR, nope, it's not going to make it. Sensitivity of stress echo, as you saw before, is not going to be very good, and specificity, and so we got bad numbers. And so new standard of care. Value, frequently 3 days in the hospital, length of stay. Cost, much more costly. Patient satisfaction, I mean, what does a cardiac cath cost? It costs a lot of money. Patient satisfaction, long waits for the doctor, they don't like that. Invasive tests, false positives. And so, but let's look at CT and talk about it. CT is capable of demonstrating what everybody's looking for, and what they're looking for is this particular lesion here, which basically is responsible for 25% of heart attacks. There is a warning. The warning is called angina. So this is a nice, clean looking artery in terms of a lesion that's pretty straightforward. You get the FFR, you look at the reduction in flow distally. If it's significant, then you can stent that. And here's an example of a stent. 25% of heart attacks. Okay, well, let's look over here. This is just a little pimple inside a vessel. Here's the equivalent of that pimple or blister on a cardiac CT. Actually, the stenosis doesn't look very severe, but this pimple can be deadly and is responsible for 75% of heart attacks, which appear as sudden death or an acute MI. No warning. And so this is the athlete that's out jogging. He's a triathlon winner, and he drops dead. This is Tim Russett on TV, who had a negative stress test the week before. And so it's rupture of a plaque. These can be identified with CT. We can tell you which plaques are invulnerable. We can make predictions off of them. We can treat them and look at them. And so this one basically did result in a heart attack. In 4 days, patient didn't take any medications. Doctor wouldn't stent it because it wasn't a severe stenosis. And so this is what we've done to make this possible. Is like any outpatient radiology center, the one we had PET, MRI, and CT, a couple $1 million worth of equipment. Has already been amateurized out, depreciated, and so all you do is add on to this the pieces of equipment that you need to upgrade this to CT. Still can do anything that you want to do in terms of radiology testing, but you can actually do it better because we lowered the radiation. Upgrade this to MRI. Need a new coil. You might need a new computer system, and so there's a couple of things you need, but not a lot. And then for cardiac PET, of course you need a gate. And for cardiac PET, the same thing. We need a gate, need a generator, we need an isotope. And so that gives us then the option of doing form, which is anatomy, CT, need heart rate less than 60. It's a 10-minute prep, 10-minute test, unless we have to get the heart rate down. CMR is basically function, cardiac magnetic resonance. 15 to 30-minute test. We've got an abbreviated test. Claustrophobia is a deal killer, and the patient has to be given some Valium. Our Versed intravenously or propofol. Every MRI can perform a quick stress test, and so we can do Lexiscan or dobutamine. We can't use Lexiscan if there's caffeine. And so these are the options that we now have, and we'll have another option. We had an option with PET in the past, but the isotope got too expensive, $42,000 for a keg for 42 days, and so that's a molybdenum generator that basically, actually it's a strontium generator, and it generates rubidium. And so we have, this is what it takes, and this is what we did to slowly build up this program of being able to do what we do today. So it started in 2006 with $75,000, and then another time we added on $200,000 to bring the radiation exposure down. And then we got a fellow training program to come join us. And now we're getting a new image system for the emergency room that'll be in-house. And we have a vital image post-processing enterprise system that we can access anywhere in the hospital or anywhere in the outpatient area. And then the PET basically had to activate a computer, purchase a cart for the generator, and post-processing computer. This was just taking a computer, it's an old computer, and turning the software on. It's pretty cheap, but unfortunately, it's too bad they don't upgrade it or upgrade the software or upgrade the computer. Just to turn it on, it's $50,000. And then there, and you just key it on with a code. You got to add a gate, and the isotope's what really costs the money, but hopefully we'll have a new isotope for Pyridaz in the future, and we'll just be able to order it up. Use only for viability at this time and whole body imaging. Otherwise, I refer patients for PET scan to Houston until we get the new isotope. And then CMR upgrade, 36 channels, $30,000. Computer post-processing, $60,000. Purchase a cardiac coil, $30,000. Add a gate. Activate the key for sequences. So it costs a lot of money. It's about $200,000 to do cardiac MRI. Unfortunately, that's a barrier to entry. You can do this by stages, though, where you could introduce stress testing first and then move on to other parts. So you can do the stages and then add T1, Molly, or a navigator to be able to look at the coronaries and to be able to do fibrosis analysis for the coronaries. So basically, this is non-invasive cardiology, old style, non-invasive cardiology called supercardiology with 4 modalities instead of 2. That gives us much greater options and stability. This is stress echo, which is fail when compared with FFR. Cardiac spec is a fail compared with FFR. PET scan, echo, CMR, CTA, invaluable. And so this is the pathway that we take now. And this is the old pathway, this is the new pathway, and this is what happens in the ER that makes things go a lot faster. And if we separate out those patients that are the 80% that are low risk, and then we try to get their heart rate down where we want it, and we pre-medicate them. We know we can't do these patients if they have a high creatinine or if they're on Viagra or one of the other phosphodiesterase inhibitors. Whatever their heart rate is can be a problem, allergic to contrast, and so forth. And then we can actually lower the radiation, which we've been doing step by step. And the next lower radiation will actually take us to 2 chest x-rays, which is extremely low, which gives us more opportunity to be able to do the test in a larger population. We'll also be able to do FFR off the CT scan. We won't need the cath lab for FFR anymore. We can get those numbers by basically simulating on a CT scan the effect of the adenosine and the effect of blood flow past this plaque. And so we're actually meeting with HeartFlow September 9th to look at introducing this into our system where we can actually measure the FFR and get that information for taking care of patients. And when CT is applied to patients with chest pain, as opposed to standard of care, which is stress and stress echo and stress spec, there's actually has been shown a 50% decrease in fatal and non-fatal heart attacks by recognizing the right patient and putting them in the right pigeonhole. And so normal coronaries, go home. Patients with minimal calcification, go home. Patient with chronic total occlusion, we can evaluate. Patient multivessel disease, we find a lot more than we used to find. And so it's efficient, it's fast, decreased length of stay, less radiation, faster, more specific results. Cardiac CAS can go from 60% negative CAS to 21% negative CAS. The 65% of people that go home that still have coronary artery disease can be recognized and basically can have bypass surgery if it's appropriate. If they have CTOs, they can be opened if that's appropriate. We have the potential for doing CT-FFR. We can do MRI with Lexa scan if the heart rate can be slowed down. We use dobutamine if the patient's on caffeine. And this results in much greater satisfaction from the people we see. And so that concludes our discussion today. If there's any questions, we'll be glad to entertain questions. And so thank you so much for coming today. Hello, Mick Gunderson. We're glad that you could come today. I just saw your name. Janet Mora, glad you could come too. And we're going to post this online at Cardiac Care Critique if you want to observe it some more. Thank you so much, everybody. Thank you, Mary Daniels.
Thank you.
Bye-bye. Bye, Mick.
Bye-bye.